Hey guys, back again with another video for you. And this video is on somatoform, dissociative, and sexual disorders. This is chapter 24. So let's just jump right in. What are somatoform disorders? Well, soma means body. We understand that already. And somatoform disorders are disorders that even though the patient has physical symptoms, and these symptoms are real, they're actual symptoms that they are generating. But despite the fact that these symptoms are real, there's no physical or medical explanation for it, nothing organic. There's no way to explain these symptoms. Generally, these patients have gone to doctors, sometimes many doctors, and there is nothing that they can find wrong with them. So it's believed that these are psychological in nature, stemming from maybe some anxiety, which the patients are not aware of, or maybe some unconscious internal conflict. And these things translate into these body symptoms, okay? Usually what they say is that there's a familial connection with these disorders. Well, some of them, like child or child abuse. Next slide, number 3. All right, so that's somatoform in a nutshell, okay? Now, let's look at somatoform versus fictitious or malingering. Okay, so what is a fictitious disorder? A fictitious disorder is a disorder that the client makes up or inflicts upon themselves. So they do inflict this particular disorder upon themselves, or whatever it is. They might poison themselves, for example, or something like that, or have many surgical procedures. Usually there is an internal motivation for this type of behavior, and that is, again, there's some anxiety that these people are not aware of, something that they're in denial of, some conflict within themselves. Maybe they're not happy with their bodies, so they continuously have surgeries. They poison themselves deliberately so that they can get some attention. Okay, so they have a secondary gain from this whole thing, which is attention, and the primary gain is that they decrease. Most likely, they wind up decreasing the anxiety that they felt. It's either blocked or decreased. So these behaviors block anxiety or decrease it, okay? Whatever it is, they poison themselves. There's also what's called Munchausen by proxy. Munchausen is, again, when they have many surgeries, for example, or they inflict some kind of disease upon themselves. Let's say the person is an asthmatic, and so they go and they're allergic to cats, and they go around somewhere where there's many cats. So obviously they're doing it. Or the mother has a child and exposes the child to an area that has a lot of cats, and then the child goes into a respiratory distress. Okay, so that's Munchausen by proxy. Okay, where the mother does that for attention, so that the whole family as a unit gets attention. So that's fictitious. Malingering is when the client consciously exaggerates false symptoms, usually makes up symptoms, usually to get out of work or any other responsibilities. Sometimes malingering can take place in the ER, you'll see a patient come in, a drug addict, especially coming up with these made up symptoms because they want to try to get drugs. So, you know, they complain of pain, etc. And also they have an external motivator, and that's to get the drugs. All right, so that's to get that attention so they can get that drug. uh, Slide 4, types of somatoform disorders. uh, Somatization disorder. Somatization disorder. Okay, so these patients basically the same. They have symptoms, but symptoms all over the place, all parts of the bodies. Gastrointestinal, uh, gastrointestinal could be heart, cardiovascular, physical, whatever it might be. Just checking my time. Okay, so usually these patients have a history of developing these symptoms prior to 30 years old. All right, and they have them for several years. They go around doctor shopping, go from doctor to doctor because the doctors, they say, can't really, they don't really they can't find what's wrong with them, so they keep going from one doctor to the next. They've had multiple testings, all kinds of neurologic testing, bloods, etc., EKGs, and everything comes out normal. Now, you usually find these patients with their records. They love to carry their records with them. They have thick pile of medical records. All right, so the diagnosis is definitely based on the fact that they come in and they have their medical records. They tell you they can't find anything wrong with me, but I know that there's something wrong with me because I'm actually feeling sick. All right, and then this is true. And again, the belief is that there's some unconscious conflict, anxiety, and this person has really needs a psychiatrist, needs some psychological help. All right, so they're not faking the symptoms. They are in distress, and they're not getting any attention for it. No secondary gains. Okay, they're doing it, and that's basically it. So on slide 5, you'll see that we have symptoms of different categories. You have GI, reproductive symptoms, neurologic, and abdominal. So it can vary. It can vary, but the patient should have a history of symptoms in various body parts: 4 in pain, and in other different sites, 2 in GI, 1 in reproductive, 1 in pseudoneurologic. Okay, next slide, 6. Types of somatoform disorders. We have conversion. Conversion disorder is a primary feature where there is loss of voluntary motor or sensory function. So what are we talking about? Paralysis, blindness, loss of taste, feeling, something like that. Okay, so that's conversion. And though that's usually connected with, there's a correlation rather with childhood traumatization. Okay, hypochondriasis. For at least 6 months, these people fear that they have a serious disease. There's no significant pathology for thinking so. Usually a rare disorder is different from OCD, where someone's just obsessive compulsive disorder is different. This is hypochondriasis. This person usually, again, they feel like they basically have this disorder. Some may manifest symptoms also, but someone might feel like they have Ebola. I have Ebola. I know I'm gonna start bleeding out any minute now, etc. Okay, or something to that nature. Now we also have body dysmorphic disorder, which is a disorder that a famous musician who died had. Body dysmorphic, right, that's correct, Michael Jackson, where the individual is preoccupied with the way that they look. their appearance. Maybe they have too many wrinkles, too many spots. They're maybe they feel that the breasts are not big enough. They don't have big enough buttocks. The hands are too big. The feet are too big, and so they feel distressed and embarrassed by that. Conversion disorder we talked about a little bit, and that's on the slide 7. So again, there's it's it suggests that there's something going on with the nervous system, or there's a medical condition, but they can't find anything. It's psychological. It's a conflict or a need that the person has. And again, we said weakness, paralysis, impaired speech, seizures also are a conversion disorder, and so on. Conversion is not fictitious or malingering, though. Slide 8, we'll pass that up. Assessment, parameters for somatoform disorder. We do mental status exam, physical exam, and social assessment. Recommendations for treatment are cognitive behavioral therapy, also selective serotonin reuptake inhibitors, which that seems to be a go-to for a lot of disorders. And with somatoform disorders, possible biofeedback, relaxation, and regular appointments with a PCP, preferably most likely a psychotherapist, and avoid unnecessary tests. These people don't need tests. It's unnecessary. There's nothing wrong. It's all psychological. And avoid recording symptoms. You don't need to ask them about their symptoms, because they're going to basically tell you the same thing over and over. Activities to assist the client with adaptation. You can read up on that. Dissociative disorders. Let's look at dissociative disorders. Basically, what's happening is here, this is a disconnect that a person is having, okay? A disconnect of self-awareness. Why is it going on? And it's an effort to escape some unsettling event or feeling. Usually kids that are abused have some form of a dissociative disorder, because at the time that they're being abused, they may disconnect from it, and they may not feel like that was them. That's the only way that they could deal with it. So it's like a blur. It's an image, but it wasn't them. They don't see that as being them. Okay, so it's a disconnect or an altering of self-awareness. We will have also a disruption in usual function of consciousness and memory and identity and perception. People will not be able to perceive certain things about themselves, especially related to the event, okay? And this is a normal method of preservation, where we kind of disconnect from things because we get so overloaded. There's probably things in your past that you disconnected from that you don't really remember, vaguely remember. You could look at it almost like a zoning out. You ever just zone out your mind? You just go somewhere else. Or daydreaming, or just an episode of amnesia, an amnestic episode. Okay, so types of this dissociative disorders. We have depersonalization disorder. So that's a feeling that you're detached from your own body or thinking. You feel like you're watching a movie. It's not even you. You kind of like feel your life is not your life. You feel like you're living somebody else's life. Now, there is also dissociative amnesia, which is loss of memory. And again, these disorders are not organic, means that there's no physical reason for this. But the individual has extensive inability to recall events or facts. All right, so that's some of it. Dissociative fugue is the same thing, a dissociative disorder, but suddenly that person winds up somewhere else, in Chicago, in the Philippines, and you wake up and you can't remember how you got there. You can't remember how you got there. You sudden travel away, and you don't know no way to. You can't put together. How did you get there? And it's difficult for you to remember your past too. Okay, and then there's also did dissociative identity disorder. Uh, this is where an individual will acquire one, or rather two or more identities or personalities who actually control the individual's behavior. Before they used to call it split personality, and now it's just called DID. Uh, Interventions for clients with DD, dissociative disorder. Okay, well, basically, talking, that always helps. Just talking to the patient. Cognitive behavioral interventions, group therapy, and psychopharmacology. Lorazepam usually is helpful for short-term management of that, of any anxiety, and that's it. Next slide. In 16, we have sexual dysfunction, basically a disruption in any part of the human sexual response. So it could be primary, and usually when we talk about primary, it's either psychological or emotional condition. So it's something psychological or emotional, and because of it, the individual's not able to function. You can't get an erection. The women usually may not be able to have desire or arousal, or they can't orgasm. Um, and so it's psychological, emotional condition, or it could be a combination of psychological, emotional, and medical. Now, secondary causes are medical condition. It's a medical or substance abuse, or even menopause or surgery, and then you have sexual dysfunction secondary to that. Blood pressure medications, sometimes blood pressure medications can cause a secondary sexual dysfunction. Antidepressants, we know that SSRIs sometimes cause that, and neuroleptics also can cause a sexual dysfunction. And now we also remember we said sexual dysfunction are subdivided into the areas of desire, arousal, orgasmic, and pain disorders. So those are 4 areas. We'll look at them real quick. In desire, we have hypoactive sexual desire or sexual aversion disorder. Okay, so these are 2 disorders: hypoactive disorder or sexual aversion. Hypoactive, you don't really want to have sex. Sexual aversion, you just want to not get into it at all. Arousal, the female just doesn't get aroused. And males, we have male erectile dysfunction. So that's kind of correlates one with the other. And then we have orgasmic, you can't have an orgasm, and pain disorder. Classifications of sexual disorder. This is slide 17. Lifelong or acquired, generalized or situational, psychological or combined. When we talk about lifelong or acquired, we're talking about have they had this all the time, or did it just come on all of a sudden? Generalized, is it with everybody, or situational, is it just with my boyfriend or my husband or my wife or my girlfriend? Is it just with them that I can't perform? And then psychological or combined, combination of all that. Sexual dysfunction with desire, again, we said hypoactive means just absent desire. You don't want a deficient or absent desire. And again, it could be situational or activity. What does situational or activity mean? It means that you don't have desire to do it because of the situation or the person, or the only way you can have an orgasm is through masturbation. So that's in a sense, hypoactive. Okay, sexual aversion disorder. Patient may experience pain, anxiety, etc. When they think about it, they can faint. They get nauseous, and the whole. So there was something going on, obviously, underneath. How did they get to this point? All right, and then arousal disorder, basically decrease in pelvic vasocongestion. The vagina doesn't get lubricated, so there's no arousal. Erectile dysfunction on the next slide, 19, um, is continuing it. Inability to attain or maintain an erection. Um, and so that's not all. And then we also have premature ejaculation, where the orgasm happens within minutes. And you know, the woman is very upset about that, because she would hope that it would last a little longer. Um, Orgasmic disorders could be persistent or recurrent. Delay, but or absence of orgasm. Now, the research shows that 75% of women do not experience orgasm. And that's okay. I mean, because you know what? You don't need an orgasm to procreate. Men need to orgasm to procreate. So that's kind of different. And it doesn't make the woman less of a woman. There's still a woman, nevertheless. Uh, and then we have pain disorders, dyspareunia. Okay, that's pain disorder. And so that's pain with intercourse. And vaginismus is when the vaginal walls spasm and they squeeze. They squeeze down. So while there is the sexual act, the woman's vagina will squeeze down on the man's penis and can clamp it. And that may prove either painful for the man, or may be difficult for them to disengage. Sexual dysfunctions, not in DSM-5 yet, but persistent genital arousal disorder this is not nymphomania or priapism in men. Priapism is when you get an erection, a man gets an erection, but it won't come down. It stays up for a long time. You know, that could prove fatal also. And usually it's treated with neurologic medications for Parkinson's, like a Parkinson med or Botox injections for the man. Usually this is for the man. Now, persistent genital arousal disorder in women is when a woman just continually has orgasms. And it could be, let me tell you a story. There was a Kim Ramsey, 46-year-old Canadian nurse. She was in the news because she said she had 100 orgasms a day. And that's a lot. You know, you just move and, you know, you have an orgasm. What is that? You know, you just move around. You move to the left, orgasm. Move to the right, orgasm. So that can really become unsettling. You know, patients have in the past committed suicide because of it. But again, there's medication that you could take, like Botox, and that'll decrease it. Paraphilias, these are other sexual disorders, intense sexual arousing or fantasies or sexual urges or behaviors generally involving non-human objects. So, I mean, you know, with vibrators or panties, and some men, women like vibrators, some men like panties or rubber items. And then there's suffering or humiliation of oneself or one's partner. That's sadomasochism. Okay, the masochist likes to be humiliated or punished. The sadist is the one that likes to inflict the pain or punishing, and these individuals get sexual arousal from that. And then there's also pedophiles who enjoy sex with children, and these are all necessary for sexual release and arousal. We talked about pedophilia, men that like, or women that like to have sex with underage children. Voyeurism is when you like to watch sex in act. the sex act being occurred, and fetishes, as we mentioned. Fetishes are with panties, some vibrators, etc. Sadism, we already mentioned, masochism, and exhibitionism. You like people to watch while you're having sex. Uh, and there are also some that you could read on your own. The paraphilia is not otherwise specified. Okay, and those are listed in the PowerPoint. You could read them. For example, there is necrophilia, sex acts with corpses, dead things, and urophilia is men or women that like to be urinated on. Okay, and they get off on that. Okay, and then there is well, cyproterone acetate, Androcure. This is a medication, and metroxyprogesterone. These are medications called Provera, which reduce testosterone levels and decrease deviant sexual behavior. These are given for pedophiles, the pedophiles to take. Okay, and then in slide 23, you could read that. There's different types of other compulsive sexual behaviors. And then we also have strategies for treatment on the last slide 24. And you can look at that. But a lot of counseling and the medication, the castration medication, basically. And that is it. And I just want to thank you once again for listening in. And you have a great day.